Hi everyone, welcome back to Global Academy of Medical Education. In this session, let us learn about which are all the drugs which are useful in the treatment of heart failure. Myself, Dr. Padmanabha, TS, Faculty of Pharmacology at Global Academy of Medical Education. So moving on to the basics, that is, what do you understand by heart failure? So always please remember that heart failure will represent a difficulty in contracting ability of an myocardial smooth muscles. So what happens in case of heart failure means there will be defect in the cardiac contractility. So heart is pumping very hard and it is very difficult to pump because it has lost its pumping ability. So there is a defect in the contractility of the myocardial fibers. So what happens due to the defect in the cardiac contractility? So there will be decrease in the cardiac output, So decrease in the cardiac output will lead to stimulation of the compensatory mechanisms. So what are the compensatory mechanisms that will be stimulated due to decrease in the cardiac output? So there will be increase in the sympathetic activity. So this increase in sympathetic activity in turn will lead to increase in the heart rate. That is tachycardia. And this increase in the heart rate, again it is responsible for cardiac remodeling. So what do you understand by cardiac remodeling? That means there will be loss of myocytes as well as there will be myocardial fiber fibrosis. So there will be loss of myocytes, there is apoptosis as well as the fibrotic changes that will be occurring in the myocardial fibers. Apart from that, it can also increase the vasoconstricting ability. It increases the vasoconstriction due to increased sympathetic activity. So this in turn will lead to increase in the afterload that will going to increase the total peripheral resistance. Whereas on the other hand, again, due to the increase in sympathetic activity, it will also stimulate the renin-angiotensin-aldosterone system. So once the renin-angiotensin-aldosterone system is activated, what it leads to is the edema. So edema because of the fluid accumulation, because of the retention of the sodium and the water, as well as there will be stimulation of the aldosterone. Aldosterone will lead to increase in the sodium absorption as well as there will be water retention leading to the edema. And this will going to increase the preload on the heart. On the other hand, there will be decrease in the contractility of the myocardial fibers. So what will be the target size so that we can overcome this heart failure problem? So there are very different categories of drugs that can be given to tackle the failure of the heart. So let us concentrate how to decrease the heart rate. So you can decrease the heart rate by giving a beta blockers. You can give the beta blockers to decrease the heart rate. Is that clear? And to increase, there is an increase in the afterload. To decrease the afterload, you may need to give the arterial vasodilators, mainly the arterial vasodilators. On the other hand, to decrease the preload on the heart, again you can give a diuretics as well as you can go with the RAS inhibitors. What are those RAS inhibitors? You can go with AC inhibitors, ARBs, etc. And also you can go with the aldosterone antagonist. On the other hand, to increase the contractility, you need to increase the contractility. So to increase the contractility, you will be giving the inotropic agent. So there are 4 things you should remember. To decrease the cardiac rate, you need to give a beta blocker, and to decrease the afterload, you need to give the vasodilators, particularly the arterial vasodilators. And to decrease the preload, you may need to give diuretics as well as the venodilators. And also you can give AC inhibitors, ARBs and aldosterone antagonist. So to increase the cardiac contractility, you may need to give the inotropic agent. So there are some of the drugs which will going to decrease the cardiac remodeling. Thereby it will increases the survival rate. It will increase the survival rate. So many times in your exams they have asked what is the purpose of reducing cardiac remodeling. The purpose of reducing cardiac remodeling is to increase the survival rate. That means to say it will going to decrease the mortality rate. So next, coming to this is the pathophysiological mechanism to the heart failure. So whenever there is a decrease in the cardiac output, there will be decrease in the BP, which lead to increase in the sympathetic activity, that will lead to increased contractility on the heart, and this will going to in turn increase the strength of the cardiac muscle contractions. So once there is an increase in sympathetic activity, this will going to cause vasoconstriction, and in turn it will lead to increase in the afterload. On the other hand, decrease in the cardiac output as well as increased sympathetic activity will lead to decreased renal blood flow. As you know that one of the important factor that can stimulate the renin release from the JJ apparatus is the decreased blood flow. So there will be increased renin secretion that will going to increase the formation of angiotensin II, and this is angiotensin II which is responsible for the vasoconstriction as well as the increased aldosterone release. And also this will contribute to the increase in the preload because of the sodium and water retention, and it can also be in turn potentiated by the increased aldosterone mechanism, which will going to increase the sodium and water retention, leading to the edema. So this will going to increase your blood volume, that is plasma volume, and in turn it will give rise to the increase in the preload. And increase in preload will lead to increased capillary filtration, and that can lead to pulmonary congestion. So altogether there will be increase in the end diastolic volume, which will in turn causes dilated heart, and this will going to decrease the strength of cardiac muscle contraction. So on the other hand, decrease in the cardiac output will also lead to increase in the end systolic volume. Again, it will going to increase the end diastolic volume, leading to dilated heart and decrease in the strength of contraction. So as a compensatory mechanism, it will lead to increase in strength of contraction. So what are the sites we can target here? So basically, you can target to decrease the sympathetic activity. What will you give? You can give the beta blockers. To increase the contractility, what you can give? You can give inotropic agent. And to decrease the RAS activity, what you can give is the RAS inhibitor. What are all the RAS inhibitors? You can go with the AC inhibitors, you can go with the ARBs, also you can go with the aldosterone, antagonist, and also release of renin from the JJ apparatus is stimulated by the activation of beta 1 receptor. You can also go for the beta blockers. On the other hand, to decrease the afterload, you can go with the vasodilators, especially the arterial vasodilators like hydralazine. On the other hand, since there is increase in the preload, to decrease the preload, what you need to give? You can go with the diuretics. You can also go with the venodilator, especially here it is the venous venodilator, that is the nitrates, isosorbide dinitrate. Is that clear? Fine. Next, we'll move on to what are all the important drugs that are useful in the CHF. So your goal has to decrease the heart rate. So again, repeating, very very important, to decrease the heart rate, you'll be using the beta blockers. So which beta blockers are preferred? Cardioselective beta blockers are preferred. Cardioselective beta blockers are preferred. So like metoprolol, bisoprolol and carvedilol, like metoprolol, bisoprolol and carvedilol as shown to be decrease the cardiac mortality among such a patient. To decrease the afterload, you will be using the arterial vasodilator. So the example will be your hydralazine. So to decrease the preload, you can go with the diuretic agent. So which are the diuretic you will going to prefer? Here you will going to prefer the furosemide as well as the thiazide group of diuretics. And also to reduce the preload and the afterload as well as to decrease the heart rate, you can also go with the AC inhibitors or ARBs. Here also you can give AC inhibitors or ARBs. Here also you can go with AC inhibitor as well as ARBs. To increase the contraction, that is to increase the force of contraction of the heart, you can go with the inotropic agent. So which are all the inotropic agent we have? We have a example like digoxin. We have beta 1 agonist. So which are all the beta 1 agonist we know? We have dobutamine. And we have a dopamine, please remember. And again we also have phosphodiesterase inhibitors, like we have two drugs, inamrinone and milrinone. So basically all these drugs, you should remember, to increase the cardiac contraction, they are going to increase the calcium ions in the calcium concentration in the cardiac muscles. So to decrease the cardiac remodeling, so you have many drugs to remember and very important from the exam point of view. So it has been asked many times which are all the drugs which can decrease the cardiac remodeling, thereby it increases the survival rate as well as decrease the mortality rate. So one such drug you can remember is the beta blockers, AC inhibitors, ARBs, you have spironolactone, but not the furosemide and thiazide. Only among the diuretic, only drug that will decrease the cardiac remodeling among the diuretic agent is the spironolactone. So apart from this, even the hydralazine and isosorbide, dinitrate, and also you have some of the drugs like ARNI. What is ARNI? It is an angiotensin receptor blocker plus neprilysin inhibitor, that is the valsartan and sacubitril. So all these drugs can decrease the cardiac remodeling, thereby it increases the survival rate among the patients. So let us see how the cardiac remodeling occurs and what you can do. So how the cardiac remodeling occurs? So please remember, whenever there is an increased activity on the heart due to the heart failure, so there will be increase in the sympathetic activity. So this increase in sympathetic activity means there will be increase in the catecholamine release. So this catecholamine will going to increase the activity of what are the catecholamines we know? We have epinephrine and norepinephrine. This will be released in excess, and these neurotransmitters or the catecholamines will going to act on the heart. It increases the contractility, thereby leading to increase in remodeling, that is the increase in fibrotic changes, hypertrophy, fibrosis, changes in the cardiac muscles. And in turn, along the activation of epinephrine and norepinephrine activity, the increased sympathetic activity will also increase the activation of RAS pathway, that will in turn lead to increase in the aldosterone activity. So as you know, what is the activity of aldosterone on the heart? It will going to increase the fibrotic changes by increasing the sodium and water retention. Sodium water retention, which will increase the blood pressure, that in turn will lead to cardiac remodeling. So what will be the targets? So you can use some beta blockers to decrease the cardiac activity produced by epinephrine, norepinephrine. You can go with the aldosterone receptor antagonist, that is only the spironolactone. Is it clear? We'll move with the next slide. That is, when we take up a case scenario like left systolic dysfunction, which occurs secondary to the coronary heart disease, is the most common cause of heart failure. So the most common cause of heart failure is the left systolic dysfunction, mainly secondary to the coronary artery disease. That means there can be some thrombus or atherosclerosis that will lead to decrease in oxygen supply and the blood supply, leading to left systolic dysfunction. So again repeating, the therapeutic goal in the heart failure is to decrease the preload and afterload to increase the contractility and decrease the cardiac remodeling. So next we'll move on to the very important group of drugs that can reduce the preload, that can reduce the afterload, that can reduce the cardiac remodeling and increase the contractility. So let us concentrate on first the drugs which can decrease the preload. So preload has to be decreased by giving some venodilators or the diuretic agent or AC inhibitor. You can give diuretics. So which are the diuretics you are going to give here? Again, you can give furosemide, or you can go with the thiazide group of diuretics. So as you know, AC inhibitors you can use, that is all these AC inhibitors end with pril, enalapril, lisinopril, etc. Then you have a ERBs. ERBs usually they end with the sartan, losartan, candesartan, irbesartan, valsartan, etc. Then you have a venodilators, that is the isosorbide dinitrate, and you have a drugs which can reduce the afterload. You need to give AC inhibitors, ARB, as well as arteriolar dilator. The example will be your hydralazine. On the other hand, to decrease the cardiac remodeling, you can go with AC inhibitors, ARBs, spironolactone, beta blockers, and also you can go with the ARNI, that is angiotensin receptor blocker, as well as the neprilysin inhibitor, that is sacubitril. Along with that, even the hydralazine will also contribute to the decrease in cardiac remodeling. So how we can increase the cardiac contractility? By giving digoxin, by giving beta agonists like what are the beta agonists? You can use dobutamine as well as the dopamine, and also you have some phosphodiesterase inhibitors like milrinone and enambrinone. So what is the common thing you can observe from these group of drugs? So please remember, here you can make out that the AC inhibitors, ARBs, AC inhibitors, and ARBs. So all these drugs, AC inhibitors, ARBs, will going to cause what it causes. There is a decrease in the preload, there is a decrease in the afterload, as well as it decreases the cardiac remodeling. So there is one more drug which needs to be remembered, that is the nitroprusside. So nitroprusside, what it does is it has got both venodilation ability as well as arteriodilation. It dilates both veins and the arteries. Nitroprusside. Is that clear? Okay, we'll move on to the other slide, that is drugs which can improve the survival in cardiac failure. So you need to remember this. Why I am repeating many times means this has been asked n number of times, and you can expect this question in any entrance exam very frequently. So again we'll concentrate. You can remember with A, B, D. You can remember with some of the dilators also. So A stands for, you can remember ACE inhibitors. You have ARBs, you have got ARNI, etc. Under B you have got beta blockers. Under D you have got the diuretics. Among the diuretic agent, it is only the potassium sparing ones. Among that, it is only the aldosterone receptor antagonist, that is spironolactone. And you can also go with the dilators, that is the vasodilators. The example will be your, which is the example, that is the hydralazine. So ARNI should not forget, it is a combination of valsartan plus sacubitril. So please remember, this has been asked many times in your exams. So again, so these are the drugs and these are the mechanism of actions. So please remember always, the AC inhibitors and ARBs will going to decrease all these three effects, that is decrease in preload, decrease in afterload, decrease in the cardiac remodeling. Whereas beta blockers, especially the cardioselective beta blockers, mesoprolol, bisoprolol and carvedilol, has got additional alpha-1 blocking activity. So this will going to decrease the heart rate, decrease the contractility, decrease the cardiac remodeling, as well as it decrease the AV nodal conduction. So when we come to the diuretic agent, loop and thiazide diuretics will going to decrease the preload, whereas the spironolactone, eplerenone, these are the aldosterone receptor antagonists that will going to decrease the cardiac remodeling. So many times it has been asked in many competitive exams that which among the diuretics will decrease the cardiac remodeling. It is only the spironolactone as well as eplerenone, which is the aldosterone receptor antagonist. So next we have some of the alternative drugs. If the patient is not able to tolerate the AC inhibitors or ARBs, so in terms of chronic therapy of CHF, you can go with a very important combination and a safe combination, that is hydralazine and the isosorbate dinitrate. So how it can help in decreasing the CHF? So basically hydralazine is a arterial vasodilator, whereas the isosorbate dinitrate is the venous vasodilator. So this will going to decrease the preload. This will going to decrease the afterload, and venodilator, this will going to decrease the preload. So this how it produces the beneficial response among the chronic CHF patients. So let's moving on to the inotropic agent, their mechanism of action. So here you can see the drugs. So here we are mainly concentrating on three group of drugs. So which are the three group of drugs? One is the digoxin, and another is the beta agonist, and you have a inhibitor, that is phosphodiesterase inhibitor. So digoxin will going to inhibit what? They inhibit the sodium potassium ATPase pump on the cardiac muscle. So basically what happens when you inhibit the sodium potassium ATPase pump here, so its activity is mainly to excrete the sodium. In exchange of that, potassium will enter the cardiac cells. Since you are blocking this pump, what happens? Sodium remains inside. Since the sodium remains inside, what happens to this activity? This sodium calcium exchange pump will be inactive and calcium will be stored here. Calcium will be stored inside. This stored calcium will in turn trigger the sarcoplasmic reticulum to release the calcium. This released calcium will act on the actin and myosin filament. This is the actin and myosin filament. This is responsible for the contraction of the myocardial smooth muscle, producing increased force of contraction. That's why they are called as inotropic agents. On the other hand, you have drugs like dobutamine as well as the dopamine. So this will going to activate the beta 1 receptors, and what it will do is it will going to increase the conversion of ATP to cyclic AMP by GS mechanism by increasing the adenylyl cyclase activity. So this increased cyclic AMP will going to activate the protein kinase A activation. This will going to cause phosphorylation of the calcium channel. There will be influx of the calcium. Again, it will going to trigger the sarcoplasmic reticulum and there will be release of calcium, leading to the actin myosin filament activity, that is contraction, leading to the increased force of contraction. On the other hand, you can also use the phosphodiesterase inhibitors. Like phosphodiesterase is responsible for conversion of cyclic AMP into the AMP. So to increase the cyclic AMP, you need to give phosphodiesterase inhibitors. So what are the phosphodiesterase inhibitors? You have enambrinon as well as mildrenon. These are the phosphodiesterase inhibitors. Again, this will going to increase the cyclic AMP. Again, activation of phosphoprotein kinase A, increased activity of calcium ion influx, leading to sarcoplasmic reticulum activation. There will be excess release of the calcium. This will lead to increase in actin myosin filament contraction in the myocardial cells. So these are the three inotropic agent. So among this, what you should remember is these has been used in chronic heart failure. But these drugs are basically used in case of acute heart failure, and even this is used in case of the acute heart failure, or you can go with the in case of acute severe decompensated heart failures. So this is the direct effect. So digoxin, when we talk about the digoxin has got two mechanisms. One is the direct effect, second one is the indirect effect. So what is the direct effect? So direct effect, as we discussed earlier, it will going to inhibit the cardiac sodium potassium ATPase pump. In turn, it will lead to increase intracellular sodium. It alters the sodium calcium exchange, and it increases the intracellular calcium. This will going to trigger the sarcoplasmic reticulum, which in turn lead to calcium release from the sarcoplasmic reticulum. This will increase the actin myosin interaction, leading to increased force of contraction. So this is how it acts as an inotropic agents. On the other hand, so this activity is useful for the treatment of CHF. In case of congestive heart failure, chronic heart failure, it is very helpful. On the other hand, inotropic agent like digoxin has got indirect effect. That means it will going to inhibit the neuronal sodium potassium ATPase, thereby it increases the firing of the vagal activity. So if there is increased firing of the vagal activity, since vagus is innervated by the heart, so this vagal stimulation will lead to stimulation of the M2 receptors in the heart. So this M2 receptor activation will lead to decrease in the cyclic AMP, leading to decrease in the heart rate. This is the heart rate. So decrease in the heart rate. So one, you have drugs which are useful in treatment of heart failure by their direct effect, and there is one more action produced by digoxin, that is the indirect effect, where this effect can be made utilized in the treatment of arrhythmias. Is it clear? Because of their vagomimetic action, increased vagomimetic action. So digoxin has got two actions, you should remember. One is it increases contractility, so therefore it is useful in the treatment of heart failure. On the indirect effect, it increases vagal firing, so therefore it can be used in arrhythmias since it decreases the heart rate. So what is the digoxin pharmacokinetic properties? So since it has got the longer T-off, longer plasma half-life, it may require 8 to 10 days, at least 8 to 10 days to reach the steady state plasma concentration. That means it will take around 4 to 5 half-lives. And since it has got longer T-off as well as the larger volume of distribution, it needs to be given by loading dose so that it can reach the steady state plasma concentration at the earliest. So since it has got renal clearance, you should be very cautious when you are giving this drug in case of the renal impaired patient. Since it has got larger volume of distribution, it can be more prone for drug displacement reaction. Especially if when it is given with verapamil and quinidine, it can displace the digoxin from the plasma bonding site because of their larger distribution into the tissues. This will displace the digoxin, leading to increase in the plasma digoxin concentration, leading to the toxicity. So digoxin, although it is indicated in two important conditions. One is in the CHF. You can give it in case of chronic heart failure as well as in the arrhythmias, that is supraventricular arrhythmias, except for WPW syndrome. And the use of the digoxin is limited basically because of the narrow therapeutic index or low therapeutic index, which requires a constant monitoring. Even a small change in the concentration can lead to severe side effects, like it can precipitate arrhythmias. So what are the side effects of digoxin? So important side effects, they can be divided into the early side effects, late side effects, and the toxic doses. So the early side effects, it will mainly affect the GIT in the cardiac system. In the GIT, it will going to cause anorexia and nausea, and cardiac activity is going to produce ECG changes because of some arrhythmias. On the late, side effects will be related to ophthalmic and the CNS. It can produce disorientation, hallucination, etc. Ophthalmic changes will be, it produces visual side effects like it can create halos, blurred and yellow vision. On the toxic doses, whenever there is an increase in the dose, so it can lead to two types of side effects. It can lead to ventricular tachycardia, that is the cardiac arrhythmias, and also it can cause AV nodal block. So how you can overcome this? By giving, whenever there is a toxicity, you can give the FAB antibodies, that is the digoxin immune antibodies. So this will going to take care of the toxic effects of the digoxin. At the same time, you need to give a supportive therapy. So basically electrolytes needs to be monitored and you need to be treated, and also antiarrhythmic agents to be given because it can precipitate the arrhythmias. So especially when we talk about the electrolytes, so you need to take care of the potassium. Especially if there is a hypokalemia, what happens? There will be increase in the toxicity. What was the reason for increase in the toxicity? The reason for increase in toxicity is, since you know that sodium potassium ATPase pump is inhibited by the digoxin. To this pump, there is two affinities. So both potassium as well as digoxin will going to compete for sodium potassium ATPase activity. So whenever if you decrease the potassium levels, so there is no competition by potassium, and digoxin will going to attach to the sodium potassium ATPase and it will going to inhibit the sodium potassium ATPase, thereby it increases the activity of digoxin, and whenever the dose is increased, it will increase the risk of cardiac arrhythmias. So only thing you need to make sure that the potassium levels has to be maintained to decrease the toxicity. So what are the drug interaction that you can expect. So since you should not make the patient hypokalemia, because it can lead to toxicities. So please avoid giving a diuretic agent, especially the loop and the thiazide diuretics along with digoxin. So because the diuretics like loop and the thiazide will going to cause decrease in the potassium, because of the loss of potassium from the urine, it causes hypokalemia, which will in turn increase the digoxin binding and digoxin toxicity. So how we can remember? You can remember it as digo, go, that is hypo, digo and hypo. It sounds similar, a rhythm is there. So hypo, digo or digo. You can pronounce digo into dico, co, that is k, that means potassium will be lowered. So hypokalemia, potassium will be lowered, that is hypo, co and po. On the other hand, you should not combine with quinidine and verapamil because of the displacement of the digoxin from the tissue protein, leading to increase in the digoxin concentration, that will increase the binding to the sodium potassium ATPase and increase the inhibitory activity. So this is the exception for the use of digoxin, that is it is contraindicated in case of Wolff-Parkinson-White syndrome. So this is also called as large re-entry arrhythmias. So basically it arises from the atria, it reaches the ventricle, etc. So the conduction accessory pathway will be activated, mainly activating the fast muscle fibers. So what you need to do in case of the large re-entry arrhythmia is to block the accessory pathway. It is mainly due to the accessory pathway there is a large re-entry arrhythmias. So you can go with the antiarrhythmic agent class 1A and class 3. Both of these class 1A and class 3 will going to inhibit the sodium potassium activity. And please remember, you should not give the drug which can slow the AV conduction. You should not give the drug which can slow the AV conduction, because again it can lead to what? It can lead to decreased AV nodal conduction. It can lead to AV nodal blocks. So once you block this, there will be increase in the re-entry arrhythmias. This will be increased. So you need to go with the drug which can block the accessory pathway, and you need to avoid the drugs which can slow the AV conduction. So please avoid giving digoxin, beta blockers, calcium channel blockers, as well as adenosine, as these drugs will going to decrease the AV nodal conduction. On the other hand, it will going to increase the re-entry arrhythmias. So coming to the phosphodiesterase inhibitors. So as we discussed earlier, under phosphodiesterase inhibitors you have got enambrenone and milrinone. So basically this will going to increase the calcium activity and thereby triggering the actin-myosin filament contraction. So basically these are useful in acute congestive heart failure only. So basically by increasing the cyclic AMP on the cardiac muscle, it will going to increase the contraction, and on the smooth muscle it will going to cause relaxation, and it will going to cause decrease in the total peripheral resistance. So please remember, it is used for chronic CHF, acute CHF only, and in chronic CHF it is contraindicated because it has been proven to increase the mortality. There is one more drug which can inhibit the phosphodiesterase 3 activity, that is the cilostazol. So where do we use cilostazol? Cilostazol is used for intermittent claudication, but they are contraindicated in CHF. And one more drug that is useful in the acute CHF only is the sympathomimetic agent, that is the dobutamine dopamine. So chronic use has to be avoided because these drugs will going to increase the risk of tachyphylaxis, that is a fast tolerance. There is one more drug, very important. This can also decrease the cardiac remodeling. So aniseritide is basically a recombinant human B type of natriuretic peptide. So it has got 3 mechanism of action. One, it will going to increase vasodilation. Second is it will going to cause diuresis, and third is it will going to cause natriuresis, increase in the sodium excretion. So by increasing all this activity is possible mainly because of increasing cyclic GMP activity that is responsible for vasodilation, and aniseritide is very useful in the treatment of acute decompensated heart failure associated with significant edema. Next, coming to the how to remember the drugs which are useful in the diastolic dysfunction. So in case of diastolic dysfunction leading to CHF, if there is a preserved ejection fraction, so drug of choice will be the beta blocker and the diuretics. If there is a diminished or reduced ejection fraction, then the drug of choice will be the digoxin. So in case of diastolic dysfunction leading to the CHF, if the ejection fraction is preserved, the drug that you should choose is the beta blocker and the diuretics, whereas the in diastolic dysfunction leading to CHF with decreased ejection fraction, the drug will be the digoxin. So next, CHF management. Coming to the summary, what you need to give is a ABD. So ABD is for chronic. So what you can use is the AC inhibitors, ERBs, beta blockers, diuretic agents. And please remember, the digoxin is an inotropic agent that can be used for chronic heart failure, and hydralazine and isosorbate dinate are the very important FDA that can be used for treatment of heart failure. And calcium channel blocker has to be avoided. Apart from that, you should also remember one more drug, that is in case of heart failure with reduced ejection fraction, FDA has approved the ERNI drug. That is a combination of angiotensin receptor blocker and neprilysin. So valsartan is combined with the neprilysin inhibitor, that is sacubitril. So why it is the neprilysin inhibitor? So sacubitril will going to increase the concentration of ANP, BNP. Those are the natriuretic peptides, or they are also called as vasoactive peptides. They are basically the vasodilators, since it prevents the degradation. So neprilysin will going to cause degradation of ANP and BNP. So sacubitril will going to inhibit the neprilysin, thereby increasing the ANP and BNP activity. So these are available orally. Basically, they are the neural endopeptidase inhibitors. It will increase the neural endopeptidases or vasopeptidase and vasodilators, and increase the natriuretic activity, diuretics, vascular relaxation. It will going to decrease aldosterone as well as the angiotensin II mechanisms. At the same time, it will going to increase the bradykinin levels that can lead to cough. So that's why they should not be combined with the ACE inhibitors. So that's why they are combined with ARBs. So this will going to decrease the cardiac remodeling and increase the survival rate. So necessitide, as we discussed, it is an atrial peptide vasodilator as well as diuretic activity, mainly indicated in the acute severe decompensated heart failure. So it is given IV, whereas the ERNI is given orally, necessitide is given IV. Only concern is renal damage and the hypotension. So again, this is the clear-cut diagram showing the mechanism of action of ERNI and the neprilysin inhibitor. That is, valsartan is used because valsartan is deprived of the brazy cough due to increase in the bradykinin. Since sacubitril is going to increase the bradykinin activity, you cannot combine with the AC inhibitors. Only you can go with the ERBs. So it is useful in the chronic heart failure. So ERNI is useful in the chronic heart failure, whereas necessitide is useful in the acute severe decompensated heart failure. So side effects will be the hypotension and angioedema. It is mainly due to the bradykinin. So this is again one more diagram, a beautiful diagram which is showing the activities. That is the sacubitril and the valsartan. So these are some of the beneficial effects produced by these two drugs, that is vasodilation, natriuresis diuresis, decrease in cardiac remodeling, decrease in cardiac fibrosis, a decrease in arrhythmia, decrease in sympathetic activation. Apart from that, you should also remember one more group of drug that has been recently approved in the treatment of CHF, that is the SGL2 inhibitors. So these are the anti-diabetic drugs. So basically, this will going to act on the proximal convoluted tubules, and it will going to inhibit the reabsorption of what it will inhibit? Reabsorption of two things. One is reabsorption of glucose as well as the sodium. So there will be loss of glucose plus sodium through the urine. So that's why they are useful in the treatment of CHF because it will going to increase the loss of glucose and the sodium through the urine. So what are the examples? These drugs will end with glyphosate. This will going to end with dapagliflozin. You have empagliflozin. They end with glyphosate, dapagliflozin, empagliflozin, canagliflozin, etc. So this you should remember. Apart from that, there is one more drug you should remember, that is the ivabradine. That is the, how it acts, it is the funny sodium channel blockers, So just to revise once, so basically, which are the drugs which are used to treat in case of CHF? You can go with the drugs which can decrease the heart rate, that is your beta blockers, decrease the preload, that is your vasodilators, as well as your diuretics, decrease the afterload, that is your again the vasodilators. So here you will going to use arterial, here you will going to use venodilators. So the common drug which can be used here is the plus AC inhibitors as well as ARBs. Here again AC inhibitors plus ARBs, again here AC inhibitors plus ARBs. And one more group of drug is to decrease the cardiac remodeling. So which drugs can be used? You can go with the drugs like ACE inhibitors, ARBs, you can go with ARNI, you can go with beta blockers, you can go with aldosterone antagonist, that is spironolactone. Please do not forget, it is spironolactone. Even you have got neseritide, sacubitril, you have got the hydralazine, etc. And one should remember that beta blockers are contraindicated in case of acute heart failure, because it will going to even more worsen the cardiac activity when you give it in a acute cases of CHF. And acute heart failure, you can go with some of the drugs like, you can go with the beta 1 agonist, you can go with the phosphodiesterase inhibitors, you can go with the neseritide, etc. Whereas all other drugs can be used in case of the chronic heart failures. Apart from that, you should also remember you can use SGLT2 inhibitor, that is the glyphosins, and also you can use ivabradines. So this was about the brief session on the drugs which are useful in the treatment of heart failure. So please go through it. So it has been asked many times in your examination. Please revise it once before going to any competitive exams, let it be FMGE or INICET or the NEET or even the proposed exam, that is the next step 1 exam as well. So this will going to fetch you more marks if you go through this topic, which is a high yielding topic under cardiovascular pharmacology. So all the best. Thank you.